Hi, this is Steve Worona, and you're listening to Campus Public Safety Online from the National Center for Campus Public Safety. Before I introduce today's session, here's a brief orientation to the Adobe Connect interface we're using. Your browser right now is showing the title slide for today's talk. On the left side of your screen, you'll see a box labeled Questions and Comments where you can read and type messages. There's a tab labeled Everyone at the bottom of this box, and that's the tab you'll use for all of your general messages, including questions and comments for our speaker. We'll be breaking for discussion midway through the presentation, so please do not hold your questions to the end. You can also send direct messages to a specific person by hovering your cursor over a name in the attendee list. One of those names is Technical Help, and that's the place to go if you run into technical problems. We're also monitoring Twitter for your questions and comments. Use hashtag NCCPSwebinar. If you miss part of today's conversation, or if you want to see some or all of it again, this webinar is being recorded and captioned. The link will be available shortly after the webinar on the NCCPS Webinars page. And watch your email for a link to a brief evaluation survey requesting your reactions and comments on today's session. Please take a minute to respond to that survey when the link arrives. We do appreciate your feedback. And now for a presentation. May is Mental Health Awareness Month, and this year, sadly, is the 10th anniversary of the shootings at Virginia Tech, which led to the tragic loss of 32 students and faculty members. The shootings have had a significant impact on thinking around campus policies and practice related to students with mental health or behavioral challenges. Schools have reconsidered mandatory medical leaves, parental notification, student at-risk and care management teams, and gatekeeper training. Today we'll review the state of college student mental health, the events surrounding the Virginia Tech tragedy, and the changes that have occurred over the past 10 years. Our speaker is Victor Schwartz, Clinical Associate Professor of Psychiatry at the New York University School of Medicine and Chief Medical Officer for the JED Foundation. Victor has more than 25 years of experience as a psychiatrist working in college mental health. Previously, he was Medical Director of NYU's Counseling Service, an original member of the American Psychiatric Association's Presidential Task Force on College Mental Health, and co-chair of the APA Working Group on Legal Issues in College Mental Health. Victor was co-editor of Mental Health Care in the College Community and is an APA Distinguished Life Fellow. Victor Schwartz, welcome to Campus Public Safety Online.
Thanks, Steve, and it's a pleasure to be here with you today, and thanks to the National Center for this invitation to speak with all of you briefly this afternoon and to talk about some of the terrible events at Virginia Tech, but also to discuss with you what impact these events have had on college and higher ed administration and mental health programs in the last 10 years since these events occurred. As Steve mentioned, we will be stopping after a bit to give some time for some questions, and we'll then be finishing up and have another round of opportunity and a little bit longer opportunity for some questions about some of the things I've covered. So I want to first give you a little bit of a sense of the context around the Virginia Tech tragedy and remind the listeners that at the time that Virginia Tech occurred, it was actually the single worst shooting incident in the United States. Up to that time, unfortunately, the shooting in Orlando more recently took more victims. But at the time, Virginia Tech was a really kind of watershed moment in this, and in fact, we're 10 years and 1 month exactly. The events occurred on April 16th. I'm not going to go into a tremendous amount of detail about the circumstances and the events. I want to focus on the things that are relevant to campus policy, to the mental health policy that have unfolded since then. But there's some great places to read more if you want to really fill in the details. The governor's report. So after the tragedy, Governor Kane put together a group of people to really look at what had happened, understand both from the administrative, mental health, and really safety perspective, what the campus did and what was missed and could be done better. The report is really kind of thoughtful and excellent and includes a tremendous amount of detail about the context and about Sung Cho's early life and the events leading to the tragedy. Also a book by Lucinda Roy, who was at the time the chair of the English department at Virginia Tech. And you'll hear a little bit more about how she was involved in some of these incidents. So her book, No Right to Remain Silent, is also a really clear and thorough review of the events. But just very quickly to give some background, Cho was born in Korea. His family came with him to the United States when he was about 8. He apparently was ill, although it wasn't clear what had happened in his early childhood, had numbers of medical procedures. When he came to the States, it was clearly seen that he was very shy and withdrawn. This had been the case in Korea as well, but it seemed as if being in a foreign setting intensified this. He also, in his early years, was seen to have suffered from selective mutism, would go for long periods of time refusing to speak. There was some thought that it might have been unease about, his lack of a good handle on speaking English. He actually did receive in his middle and high school years, he received treatment. He was for a while on antidepressant medicine, had gotten various talk therapies, and the sense had been, at least, and this is taken up again very clearly in the governor's report, that he had done well when he was in treatment, was more effectively engaged in school, became a little bit more sociable, but always remained withdrawn and shy. There was concern after the Columbine shootings. He seemed to have been very caught up with those reports, wrote a number of essays that were, he showed a real preoccupation with those shootings, specifically with violence, with school shootings. And these were among the things that led teachers to get him into the mental health system. During his college years, his first 2 years, he didn't really much come to anyone's attention, as is not unusual with people who are quite shy and reserved, which he continued to be through those years, but had some simple interactions with the medical office in his sophomore year. Started out with a focus in science and technology, which is really where he seemed to have done well in high school. In his sophomore year of college, he began to become more interested in writing, and actually over the summer after his sophomore year, he put in a proposal to a publisher with a book idea which was rejected. And the book idea, I think, had to do with some themes that were related to violence. In any case, the proposal was rejected, and it appears in his the fall semester of his junior year, things really began to come undone. There were a number of classroom incidents. There were a number of dormitory incidents. Early on in the semester, he was living in the dorm. His roommates took him along to a party. He sat there speechless, but took a knife out of his pocket and started stabbing the rug in the young woman's room that the party was taking place. Nothing happened as a result of that, but again, more and more peculiar behavior began to emerge during the semester, to the point that in one of his classes, actually a writing course with the rather well-known poet Nikki Giovanni, he was found to have taken pictures under the desk of some of the young women. They had complained. His behavior in class was sufficiently disturbing that actually the other students went to Professor Giovanni and said that they were uncomfortable coming to class with Cho remaining in the class. At that point, actually, she went to the chair of the department, and who was this Lucinda Roy, who wrote the book that I mentioned previously. Dr. Roy began giving Cho private tutorials in her office in order to sort of accommodate both the other students in this class and to continue forward progress. She also was sufficiently uneasy by him, both his unresponsiveness and the intensity of his stare, that she was uncomfortable sitting alone with him in the room and typically had someone else join them when she had these tutorials, just to reassure her that she was safe and that things were okay. Further, there were a couple of stalking incidents where he sent several young women in the dormitories very disturbing messages, text messages and emails, left some things on people's doors that were very disturbing, and this brought him to the attention of the school discipline office, who met with him about that time. He did reach out to counseling, never actually kept the appointment, although he was briefly triaged. At the same after actually the second of these incidents, he texted someone that he was feeling suicidal. The student took this information to the campus security, and Cho was actually brought to a local non-school-based outpatient service for an evaluation. And this is an important issue here because at this evaluation, he was not deemed to be needing emergency admission to the hospital, but the judge who assessed the evaluation deemed in consultation with the psychiatrist that he was mandated to outpatient treatment. And the thought was that this treatment was supposed to have occurred at Virginia Tech's counseling service. Somehow this never happened. And that's an important, obviously, problem and concern. So there was actually a legal mandate for Cho to receive outpatient care, which never occurred. It's not clear. There was supposed to have been a fax that was sent from this service to the school's counseling service. That fax was not able to be located after the tragedy. So clearly, in this period of time, there were a kind of crescendo of more and more serious problems. Through this period, Dr. Roy also contacted numbers of offices, including the counseling service, student affairs, the discipline office, and in each case was told that nothing could really be done because at this point nothing dangerous had happened and Cho could not be forced into treatment on the basis of the level of discomfort and the information. But there were all of these different events, some in housing, some in classrooms, some in other settings and interactions with other students, none of which were ever really kind of pulled together to create a picture of what was occurring through the first semester, the spring semester of junior year and first semester of senior year. Things appear to have quieted down. There was no attention, although, again, a number of things that Cho wrote in his classes made his faculty very concerned. A number of faculty went to Professor Roy, again, with concerns about the violent and in some cases, bizarre violent preoccupations that Cho had, and expressed concerns about these writings, and she, given her experience not having gotten anywhere with the various offices she contacted, basically said as long as he's not doing anything that seems dangerous, there's nothing we can do. We do know that starting the beginning of his spring semester of his senior year, he began to gather firearms. He ordered guns, he rented a van, which he kept for a month for unclear reasons, but began ordering firearms, which again we'll talk to this issue a little bit more later on. To come just briefly to the events of April 16th, 2007, what was unusual, particularly unusual beyond just the magnitude of what happened, was the fact that there were actually two separate incidents. There was an initial shooting very early in the morning in one of the dormitories in which Cho killed two people. Then he left that dorm, apparently made the famous tape that was sent along to NBC, although parts of that had been made before, and he mailed the tape during that time. He had also practiced what he was going to do in the several days before. He then entered later on in the morning a school building in which the tragedy occurred. So one of the things that presented a challenge to the campus security people and administration was that it was very unusual for there to be a two-episode event such as occurred. One of the other challenges that the Virginia Tech police, who, by the way, are state police because Virginia Tech is a state institution, so their campus security are part of the state police force. The campus is a huge campus. It's, I think, about 120 acres, which at least by New York City standards covers a tremendous amount of space, and multiple buildings, most of which did not have any security at the front door. The classroom buildings were all open, unlocked, no security guards checking IDs. The dorms did, but I think you were able to swipe with a school ID into most of the dorm buildings. So at that time, because of the size of the place, there were real breakdowns in communications. It took the school 2 hours to send out any kind of warning. They did have an emergency email system that had been until then really used for weather emergencies only, so it wasn't something that people really paid attention to. So that was one of the major also challenges of managing a crisis like this on a campus, which didn't have a strongly robust system for dealing with a crisis of this nature and of this magnitude. There is a question, and I'll just talk about this briefly now, but there was an ambiguity in Virginia state law because he was remanded to treatment, but it was only outpatient treatment. His name was not put into the federal firearms system for people who had been committed to a mental health facility. And that was why, although he was technically committed to treatment, he was still able to go on the internet and buy firearms without any problem at all. That's, by the way, something that was changed in the immediate aftermath, so that now in Virginia, anyone who has even an outpatient commitment, their name is submitted to the National Registry. Okay, so again, I don't want to talk about the details of the events. I think we've covered that in sufficient detail to give you a sense of what the issues were. But just to quickly go through, clearly what were identified in the aftermath of this tragedy, and I think I've kind of made this clear, there was on campus a real failure of communication during the crisis, and that's obviously something that became quite clear, that there wasn't a robust and efficient and nimble system in place. But in a broader sense, there was a real failure of the system to connect really what was a lot of information and a lot of concern from multiple different fronts about what had happened and about the fact that this fellow was very, very troubled and had behavior that frightened and made numbers of people uneasy. So the information was not connected among, again, the discipline system, what happened in the classrooms and the dorms. Also, again, think back to what I've said, there was a breakdown of communication between the local mental health system and the campus system. So that was another place where things were unfortunately broken down. And unfortunately, there was a breakdown between Cho's pre-college life and his college life, because, again, if you recall, I mentioned that when he was in treatment, his behavior seemed to be more contained. He seemed to have, stayed on track better. And when he came to college, there was no apparent thought about any kind of transition of care plan. And this is somebody who had received significant amounts of care during his middle school and high school years. There was also within the system, and part of this breakdown in communication seemed to be driven by a kind of overemphasis of FERPA, a kind of fear of what of sharing information that would be helpful and important for people to have among the campus administrators and disciplinary people and mental health people, which seem to have presented a real impediment of there being any kind of coordination of plan. And one of the problems that was obvious was, this balance of at what point is somebody's psychopathology more than is tolerable on a campus? If students are coming to a professor and saying that they're so frightened of someone because of the things he's saying and the way he's behaving that they can't sit in a class, should at least a mandated assessment have happened at some place along the line? So I just want to quickly go through, before we take a break for some questions, what were some of the government and law enforcement responses right in the aftermath of this event. And then the second half of the program, I'll really focus in on the mental health piece of this equation. So immediately there were reviews of this event, and again, because of the magnitude of it, both President Bush at the time and Governor Kane put together commissions who presented reports. And the President's report, the group who did that was also excellent. So both of those, if you really want to learn more, are great resources. They're both freely available online. It was, as you might expect, one of the things that happened in the aftermath was a real proliferation of systems and programs for emergency communications on campus. And this, as cell phones have proliferated and various kinds of platforms like this have become more and more common and easier to do. Campuses in the immediate aftermath were commonly doing drills, and I think, for better or for worse, that's probably diminished in regularity in the last couple of years. And one of the other things, this has been something that's evolved over time, is that, it used to be the case when there were active shooter situations, law enforcement, and probably many of the listeners to this know more about this than I, but typically the law enforcement people would kind of set up a perimeter and begin discussions. And since given the proliferation of some of these active shooter situations, the model has changed to a much more active approach to engagement, where the police and law enforcement people really kind of storm the location as sort of assertively as they can. But again, that's a discussion more for your folks, and I want to focus here on the mental health issues. And one of the other things that we saw happening is that there were many schools began to think about whether or not their campus security people should be armed. In most places, campus police are not. They are private and not part of the local police force. In most places, they're not armed. And obviously, as a corollary to this, in the last 10 years, there have been a greater push to try to push for campus carry options, which I'll say a little bit more about when we conclude later. So at this point, I'm going to just stop for a few moments, and I think Steve is going to hop in, and we'll see if we can take a couple of questions.
Yes, thanks, Vic. And before I do hop in, some folks have noted, and it also appears in my earpiece, that you are sort of fading in and out. And my guess, as it sounds to me, I think there are times when you are turning away from your mouthpiece. So
my mouthpiece just may be moving around. Is this better?
That is better, at least to my ear. So thanks. And so yes, for those of you who arrived late, we are hearing from Victor Schwartz, who was telling us about 10 years after Virginia Tech, impacts on campus mental health. This is Campus Public Safety Online from the National Center for Campus Public Safety. We will be taking questions during the presentation. Type them into the blank line in the chat pod on the left side of your screen. And we will save those questions for our various Q&A breaks. But in the meantime, CSU East Bay Care Team asks, was Cho storing firearms in his dorm room?
I'm not sure. I think that he was keeping them in this van that he had rented. So I do not believe, but I'm not certain. I would have to go back and look. It's an interesting question, but I think he was not.
You said that one of Cho's professors had private tutorials with him because students were uneasy having him in class. Is this something that's expected from schools?
Yeah, I don't think it is at all. And this is one of the things that to me should have been a red flag that there was something, deeply wrong. In some ways, although in retrospect this is hard to say, Virginia Tech was being incredibly tolerant and supportive of somebody who was, obviously a very, very troubled fellow. And they were bending over backwards to be tolerant and to make things work. And I think part of this may have been driven by some sense that this is what the law dictated, which it really doesn't. But there's absolutely no expectation that somebody whose behavior is so disturbing that other students can't sit with him or her in a class. The school is not required to set up private tutorials. That really should have been something that would have alerted them to the fact that there needed to be something else that had to happen here.
I'm going to squeeze in one more question during this break. Again, before I do, let me deal with a logistical thing. CSU East Bay, you wondered if the PowerPoint screen was blank. I don't believe it is, and technical help should be in touch with you separately to deal with that. Thank you for asking the question. This final question, Laura Lefebvre wonders, do you have any kind of statistics on how many college campuses are armed with proper assault weapons to respond to such a shooter and undergo frequent active shooter response training?
Yeah, I think most are not. And let me just say something to put this statistically in perspective. Although there have been very public and very notable shootings and mass shootings on campuses, the homicide rate on college campuses is lower than any other setting in the United States. So, and we have good information about this, and again, I'm sure many of the listeners are more familiar with this than I am, but the rates of homicide on college campuses hover somewhere between 1 per 500,000 or 1 per million students per year. I know at the time of the Virginia Tech shooting, the Cleary information, there were about 15 homicides reported on campuses a year, with about 15 million students. So the risk of these kinds of events, we should all remember, is actually incredibly low. So whether colleges are well served by spending a lot of money on high-power armaments, is certainly something that could be debated, rather than doing some more training with their protection offices and security offices, or simply hiring more officers. It's not a simple decision that the way to go is to have people with high-power rifles and investing in things like that.
We have lots of questions coming in. We will not lose any of them. We are tracking all of them. But in the meantime, Vic, I'll let you get back to your presentation, and we will get to the large number of questions at the end.
Okay, thanks, Stephen. I'll try to keep moving quickly through the presentation so that we have time for some questions and discussion. So just a quick overview of the state of mental health now of college students, because it's important to remember that this was not just a mass shooting, but it was a suicide homicide, and we need to understand what the mental health context is currently. So it's typical now, and this has been the case and growing, that that 10+% of college and university students are seen in their school counseling services over the course of a given year. And, it's not unusual for 20 or 20+% to have had some interaction with the counseling service, either attending a program, doing a screening, having some kind of group. Schools and directors year after year have reported that they're seeing more students with serious psychopathology. There's, of course, a good news, bad news here. To some extent, this may reflect better treatment and more students being accepted to colleges in spite of serious mental health problems through their high school years. But clearly this has put strains on the systems and in some cases on the colleges. We're seeing in the last 5 years or so increases in reports of anxiety among college students. Depression rates have been stable but high. And in the last couple of years, we're seeing increasing reports of suicidal ideation and suicide attempts. We don't actually have hard data about suicides in colleges for the last several years. The last careful review of this stops at 2009. There's no organized data collection around suicides. But again, suicide attempts and ideation have crept up in the last few years. A bit of good news is substance abuse and substance misuse on campus is high, but has not been increasing in the last few years. Again, some of the increasing use of services, we're not absolutely sure whether this is a bad news story or a good news story, and it probably is some of both, because again, there are more students coming with more serious problems, but at the same time, we have a sense that we've made some headway in destigmatizing help seeking and really getting care. So this seems like a little bit of good news too, that students are reaching out for help. So with that sort of platform or foundation in mind, what changed after Virginia Tech in terms of policies? Well, as you might imagine, one of the things that colleges and universities have always dealt with, given the population of young adults who are, in many cases legally adults, but developmentally often not so clearly adult-like, there's always been this tension between when do you contact family, when is information shared within the system as a matter of safety versus respecting the privacy and autonomy of students. And there are important implications here. On the one hand, parents obviously and families have a serious stake in knowing what's going on. On the other hand, if universities and counseling services and student affairs office have too low a threshold for sharing information, it will actually impede students from having the trust in the system to come for care. So it winds up actually sort of working against us if we have too low a reporting threshold. But, not surprisingly, Virginia, after the event, passed legislation essentially creating an affirmative responsibility for counseling services and university administrators in the face of a student who may be either threatening or at risk, imminent risk for suicide. There was an affirmative responsibility to contact the family unless they were aware of reasons not to. But they did give them some wiggle space. And obviously leave it to the clinicians and the administrators if they have concerns that that might make the situation worse, then obviously they're not going to find somebody culpable. The other thing, the Department of Education, in noting how much the fear of FERPA, as I called it before, impeded administrators and clinicians in the system from communicating with Cho's family, from communicating with each other, issued guidance soon afterwards that essentially tried to calm schools down. And while FERPA is, obviously a serious thing, it's a sensible and reasonable law, at the same time they didn't want the kinds of concerns that they were hearing from people at Virginia Tech about getting trouble with the federal government because of FERPA to impede people making necessary communications. So they released this statement that they wouldn't substitute their judgment for that of the agency or institution when there was a concern about danger on campus. The other thing that has continued to be a source of some complication and confusion is really what are the thresholds for things like mandatory treatment, mandatory assessments, and mandatory leaves. On the one hand, some schools after Virginia Tech were very quick to try to withdraw any student who might have any kind of hint of suicidal thought or behavior. On the other hand, there were schools that believed you could never do it, and as is so often the case, the truth is somewhere in between. But this is a really ongoing, complicated issue. It's important to remember, though, that the rates of suicidal thinking are actually quite high. So nearly 10% of students will report that they've had serious thoughts of suicide in the prior year, while only somewhat less than 1 in 10,000 will have actually a suicide on campus in a year, and the rate is somewhat lower than that, at least the last numbers we have. So just think about the fact that there are 1,000 students with suicidal ideation for each student who dies by suicide. So if you sent every student home who had suicidal thoughts, you'd be sending home a lot of people who might actually be better off staying in school for a variety of reasons. So this is, again, a very complicated issue around policy, and this slide seems not to be filling in for some reason. Let me see where we are. For some reason,
it was slide 10 where you said you were having problems. There may be some bandwidth problems. So why don't you just go ahead, assuming that other folks can see slide 10?
Okay, so I think that's where we are. Right, so this is actually a kind of important introductory comment. What has actually happened on the campuses? And the thing that we've really seen since Virginia Tech is more and more campuses are recognizing the importance of connecting those dots, of figuring out ways within the parameters of FERPA and the relevant ADA laws to have the proper administrators and offices communicating with each other. And this really has two advantages. One is that it does connect the dots. You're figuring out how to get information from one place on campus to the other. And at the same time, it's actually a source of greater efficiency. Having health services and counseling services and academic advising and the disciplinary systems in some kind of contact with each other actually winds up being something that is a cost and time efficiency for many, many campuses. So what does this look like? And more what we've seen is that campuses have taken this kind of community public health approach, which is really something that we've worked on a great deal at the JED Foundation. I mean, in some ways, this is the hallmark of how we work on things and how we try to do things and work with colleges to think about mental health and mental health care on campus from a system-wide perspective. And I'm pushing ahead, and this next slide is still not coming up. But what I'll tell you about is the single major way that this gets put into play on campuses is through the use of student at risk or behavioral intervention teams. And while these things did exist prior to Virginia Tech, it has really proliferated and become clearer and more thought through, and actually in some states I think they have been mandated, although in many cases it's not become clear what exactly is meant to happen. So just to frame what this is, I mean, student at-risk teams are ways of various stakeholders on campus, from student affairs, from the academic side, from counseling plays a peculiar and special role, but student discipline, legal affairs, really the range of people who might be in touch with students get together and work together to try to take in information, have easy conduits for information to come into the system. The information gets shared within this committee, and a plan of action for addressing the concerns or problems are developed. Now, one of the big questions, and when you'll see the PowerPoint, which I guess will be available after the presentation on the website.
Dick, just to let you know, I believe other people are seeing the slides advance, so I believe that your problem now is located. Right. So I can advance the slide for you. Just let me know when you want to move to which slide.
Okay, so we're at the at-risk student teams, and we'll move ahead in just a moment, right. So the big dilemma and the big thing to think about, and I suggest that you take a look at this Campus Teams resource because it really fleshes this out nicely, is the question of right after Virginia Tech, as you can imagine, there was a strong impulse to develop threat assessment teams, which were really focused on students who may present a threat to the community. But in fact, that kind of behavior is quite rare. And I think what these folks who took this approach recognized was that the teams wound up not actually spending a lot of time and having a lot of opportunity to work on these issues. And the campuses have realized that it's much more productive and effective to really focus on looking for students who are struggling emotionally, who are coming into academic risk. Very often those groups are highly overlapping, and really trying to intervene before students get into difficulty. Oh, there we go, thanks. The opportunity to intervene before a student gets into a crisis makes a tremendous amount of sense, obviously from the safety perspective, but also from the student's own safety and performance. In many cases, you can really head off academic and mental health problems at the pass if the system works well. The counseling service plays a role really in these systems as a consultant, and if you go to the Campus Teams guide, you can see a discussion. I don't want to spend a lot of time because it's a little bit complicated what kind of role and how the counseling service can help to direct conversations without sharing problematic information. Steve, if you can push ahead to the next.
Yep. Okay, we're now showing slide 12.
Okay, great. So one of the broader areas, and I wanted to highlight the at-risk teams because that's been probably the single most specific and important change that's occurred in the way people have thought about campus mental health. But broadly, if you think about what's happening with those teams, what we're trying to do is find ways to identify students who might be at risk for mental health problems across the whole gamut, from anxiety to depression to suicidality, and unfortunately in rare cases to students who may present a risk to others on campus. So there are a bunch of other ways that you can bring people into the system, and one of the important ways has been the proliferation of gatekeeper training programs. If you think about it, on every campus and every closed community, there are people who tend to have more interaction with others on the campus than other people do. Those would be, faculty who teach certain kinds of courses. Think about people who teach freshman writing classes, small seminar classes, people in student affairs who are working in clubs, and people in res life, chaplains, obviously, and interestingly, people in athletics, especially athletic trainers, tend to have real kind of personal interactions. And when you think about gatekeeper training, you can then broaden it into how do we educate the whole community in a basic way about mental health and how to identify people. One of the things we try to convey is you don't need expertise. that most of us really recognize when someone is struggling. Often we don't want to see it or don't want to really acknowledge it, but we often know. So having people know about when people are at risk and know what the resources are on campus to get help is very, very important. Adding screenings, the health services see many, many students, 50 to 60%, in some cases even more, will have a visit at the health service in a year, making sure that they're alert to potential mental health problems, even if the student's coming in for a straightforward medical problem. And making sure that students are reminded. It's important to recognize that none of these things are one and done. In order to get this kind of percolating through the campus, you need to do this in a way where you're reminding people about it regularly, but not in a way that's hysterical or intrusive, because that can actually wind up making people anxious. Okay, if we can go to the next slide.
Yep, we're on 13.
Thanks. So on the one hand, we're identifying people who are at risk, and if you look at it, though, from the perspective of the student who might be struggling, how do we get them to come for help? What are there things we can do that make that more likely? And it turns out there are quite a few things. As I mentioned before, transition of care was a serious gap in what happened with Cho, sadly, and we have, at the JED Foundation, we actually have through a new website called Set2Go, which you can find at set2go.org. We actually give a kind of template for thinking about as a young person who's had mental health problems through their high school years, how to think about making sure that there are no gaps in their treatment as they go off to college, which unfortunately I think was a significant ingredient in Cho's deterioration. Schools can do online screening tools and have screening days which educate people in general about mental health issues. And there can be educational efforts to destigmatize mental health problems and to educate people. It's important to try to have multiple points of entry into the system, so that students know that there are a bunch of ways and that it's easy to get care. And again, communication with the important offices that are working with a lot of students around advising and counseling, making sure that those people know each other and alert each other and consult with each other when there's a concern. And there are student populations that we know are at higher risk. Obviously, in recent years, veterans, international students, first-gen students are all groups that schools need to think about how to get them more comfortable with coming for help when that need arises. And if we can go on to the next slide.
Yep.
Okay, great.
Changes in clinical services, slide 14.
Exactly, right, thank you. So as I've mentioned before, in this approach of trying to integrate care across the system more and more, there has certainly been more integration over recent years. And this doesn't require that services actually be merged with each other, but the health and counseling services have recognized, and we know very well that many people with mental health problems and actually many people who go on to die by suicide will have had an outpatient medical visit within a month or so before their death. So having health service clinicians alert to mental health problems is really essential at this age. Many people come feeling they have a medical problem or just generically wind up coming in. Doing screenings at the health service are really important. And, again, many of you are probably aware that we've had a growing problem with drug overdose in addition to the ongoing concerns around suicide. And many people who are misusing substances are also people struggling with other mental health problems and are at risk for overdose or suicide. So increasing access to the opioid antagonist naloxone is something that's become more and more common in the last several years, and making sure that there is 24/7 access either on the campus or through national or local services to emergency services and hotlines is really important. There shouldn't be gaps in access to service at any point. many people have difficulties in the middle of the night when they're feeling more isolated, having trouble sleeping, and that's a time where it's really important to have access to some kind of communication. And just to emphasize again the importance of having coordination with community clinics, which is something that broke down in the situation at Virginia Tech. And if we can go to the next slide.
Slide 15, challenges remain.
Thank you. Right, great. So there continue to be, obviously, there's still a lot to work on in the area of college mental health and suicide prevention. Budgets are obviously, I'm sure all of you are aware, are challenging everywhere, which means that staffing of services is still thinner than ideally it needs to be. At the same time, the ability to get care outside campus in the communities has probably gotten more and more difficult over the last 10 years in many areas. There's still these kind of tensions and unresolved concerns about the legal and policy issues around, again, sharing information, contacting families, mandated leaves of absence. If anyone's interested, next month, SAMHSA and the JED Foundation, I'll be doing, together with some folks from SAMHSA and some others, a webinar on some of these ADA and Title II mandated leaves of absence issues. So check out SAMHSA's website. You can find that. There continue to be conflicts over whether it is sensible for people to be allowed to carry firearms on campus as a means of protection. When you think about the fact that 30% of students endorse that they will have an alcohol binge every 2 weeks, the thought of more people carrying firearms on campus is a little chilling. I've had many campus safety and security people tell me that in the context of a active shooter situation, having people having a shootout makes it very difficult, obviously, to tell who are the good guys and who are the bad guys, if you will, if I can be a little bit glib. But obviously it creates a much more confusing and volatile situation. And just something that's often not talked about enough, but something that was brought up by the, unfortunately, by the Virginia Tech situation is that stalking, which is a not completely rare phenomenon in which we saw elements of in the Virginia Tech situation, is a highly dangerous and volatile situation, and I think we still don't have a good enough handle on how to manage incidents of stalking on campus, whether they should be done, you know, how the discipline office and local law enforcement and counseling can work together. And the other very difficult and volatile situation is this is the age in which many people have the emergence of psychotic illnesses. And psychotic illnesses at this stage have a high risk for suicide and some risk for violent behavior. And in some ways, the early psychosis is challenging because these people don't look the way we imagine people who are suicidal look. And that creates another challenge for really being able to get a handle on these situations. And the next slide will take us to the end.
Final thoughts. So
just a couple of final thoughts. Virginia Tech was obviously a unique and nearly incomparable tragedy. It really did change the way people felt on college campuses subsequent to the events, and unfortunately there were several copycat and situations, and there have been subsequent shootings like this. But it did, in fact, really draw some attention to the importance of safety and mental health services and systems on college campuses in a way that obviously was unfortunately way too dramatic. But there have been some elements of progress that have grown out of this terrible tragedy. And, you know, in some ways, some of us have thought that college systems for mental health in some ways are actually leaders. because we've been faced with having to deal with the aftermath of things like this, well, college campuses and the ones doing it well have been at the forefront of integrated care, which is now just becoming adopted as a kind of national standard for how we should be doing mental health and actually health care across campuses. So I think we have some time for questions, maybe not as much as we had hoped, but still a bit.
We do, and we'll get to as many of them as we can. And Vic, I'm going to see if I can prevail upon you and tell people that for those questions we don't get to, if we can send them to you and perhaps have you provide some written comments that we'll be able to post on the National Center website.
Sure, would be happy to do that.
Tremendous. So Roy Grabo wonders, at the time of the Virginia Tech rampage shooting, I believe about 50% of major universities had a behavioral intervention team. That increased to about 75% within a year or two of Virginia Tech. Do you know the percentage of major universities that now have behavioral intervention teams?
Yeah, my guess is it's really probably pushing on 90. I don't know that with authority. There are probably groups out there that would have this information more precisely. But the question is, how are they functioning? And I think the range of how they're functioning is really very variable. Again, as I said before, from those that are more strictly focused on threat assessment, which are probably way less active, to those that are really looking at how do you try to identify upstream students who may be heading into difficulty and really help students who are at risk. Actually, I see Jeff Pollard is typing, and he might know this number better than I do. Oh, he stopped typing. Okay.
In the meantime, Katie Hanna wondered, what is the link for the SAMHSA JED Foundation webinar that you mentioned? She can't find it online.
So the webinar hasn't been announced yet, but either if you sign up for the JED newsletter or check SAMHSA, they have a listing of the webinars. The site will be going live, I think, in the next couple of days. So if you keep an eye on the SAMHSA website on their webinar page, you'll see the registration page very soon.
Robert Sommerfeld wonders, are you familiar with mental health support teams that are comprised of multidisciplines, law enforcement, and mental health providers? If so, do you feel teams like this could have made a difference at Virginia Tech?
Yeah, I mean, the teams ought to be multidisciplinary, and many of them actually have membership from a bunch of offices in campus, and depending on, how they run, not everybody always needs to be there. The challenge is that the people from counseling are limited as to what they can share about students who are in treatment. But they can be very helpful in directing what are reasonable steps to intervene with students of concern. And yeah, I believe if there had been a functional care team on Virginia Tech's campus, particularly given the fact that Dr. Roy had reached out to multiple offices, none of whom ever spoke with each other, sadly. I think if that information had been put together, that there were so many different places where Cho's behavior was raising real concerns. I would hope, and I think we've come to a place where it would be much more likely that there would have been a more assertive plan to try to address what was happening with Cho.
And Vic, you were right. Jeff Pollard was answering that question. He said it's now near 90% properly trained campus threat assessment behavior intervention teams have the capability to manage both those at risk as well as those who pose a risk. It's not an either-or choice. Good teams do considerable community training, networking, and welcome referrals for those experiencing any mental health issue. Let me see if I can squeeze in a couple more questions before we have to sign off. Chris Lukanja wonders, nationally, what percentage of incoming students have pre-existing mental health issues?
The answer is we don't know, but the fact is that rates of anxiety disorders and depression are pretty substantial among high school students, and fortunately, this has no longer been such an impediment to getting into college. So, it's not unreasonable that 15 to 20% of students who are coming to college have some kind of history of either an anxiety or depressive disorder, or potentially something more psychotic disorder as well.
One more, and again, we will ask Vic to take our unanswered questions and provide some written answers for them. But in a few seconds, Vic, it's a lot to squeeze in for this, but what advice would you have specifically for those who work in alcohol and other drug prevention related to this topic?
Well, again, it's really important that you are alert to students who seem to be deteriorating, that you have good connections with campus discipline and certainly with the counseling services, that you're thinking about not just the substance abuse. We make a big mistake, particularly at this age, to silo these concerns. And many people with mental health problems at this age are misusing substances, and many substance misusers are exhibiting mental health challenges. So, the work needs to be really integrated as well as possibly can within the confines of privacy and the other concerns and administrative concerns around separate offices, if they are separate offices.
Thanks very much, Vic. Thanks to all of our viewers and questioners from around the Internet. Check the NCCPS webinars page for a link to the captioned recording of today's presentation, as well as a link to our speaker slides. The brief evaluation survey I mentioned earlier should already be in your mailbox. It will take you no more than 2 minutes to complete. Please do. We read and act on your comments. We won't be presenting a webinar in June, but mark your calendars for our July webinar. On July 18th from 2 to 3 p.m. Eastern Time, we'll welcome Allison Kiss, Executive Director of the Cleary Center, to discuss top 5 challenges with the Cleary Act and Title IX. Watch your email for more details. And while there's no webinar in June, we're pleased to present our second annual Trauma-Informed Sexual Assault Investigation and Adjudication Institute in Washington, D.C. The Institute curriculum includes modules on 15 topics, from institutional obligations to self-care. The Institute will be held June 12th to 16th and consists of our 4-day flagship curriculum, followed by a 5th day of presentations and discussions with a range of federal partners. For full details, including faculty biographies, hotel information, and a link to register, click the link on your screen or visit the NCCPS website at nccpsafety.org. That's nccpsafety.org. Campus Public Safety Online is brought to you by the National Center for Campus Public Safety, with support from the University of Vermont Continuing and Distance Education and the U.S. Department of Justice. Special thanks today to Megan O'Neill. This is Steve Worona. See you next time on Campus Public Safety Online.